Okay. So good evening all. We are dot 5. So we can go ahead and start on this webinar. So request Dr. Asha to welcome all. Dr. Asha.
Dear friends and experts, today I take a big pride representing PATH in South Asia and organizing such a kind of webinar on viral hepatitis in the South Asia region with a spectacular moderate and the mind-boggling discussion that we are waiting to hear from these pragmatic and experimental minds of these participating panel members. I am also happy to invite all the participants who have joined from across the globe reflecting the theme, We Can't Wait. The purpose of this webinar is twofold: to join hands with government, civil societies, and communities in South Asia for a concerted effort in responding to viral hepatitis, to provide a common platform of resonating thoughts, unheard voices, and priorities for greater reach. Further, it's my pleasure to introduce the moderator today, Dr. Samiran Panda. Dr. Samiran Panda, an eminent scientist with more than 3 decades of experience, served as Additional Director General ICMR and Head of Epidemiology and Communicable Diseases. Recipient of many prestigious awards, including Major General Sahib Sachai Award and Science and Technology. As a research evaluator and trainer, he has worked in Bangladesh, Nepal, Sri Lanka, West Indies, and Cambodia. He has led and guided the outbreak investigation in Unnao, leading to public health action against viral hepatitis. Having more than 100 peer-reviewed publications, including the insightful and influential study on hepatitis in Punjab among people who inject drugs. We are happy to have you here, sir, and request you to take over the panel discussion. Thank you, and over to you, sir, Dr. Samiran Panda, sir.
Thank you, Dr. Asha, and thanks, a big thank you to PATH for organizing this webinar, which is of immense importance. The disease phenomena, I would say, because hepatitis is not a single disease. So we'll get to know about this particular disease phenomena in details shortly. But this disease phenomena has brought us together. 28th of July is the day, World Hepatitis Day. But interestingly, earlier, when I say early or earlier, it is earlier than 2010. Different agencies and different individuals would talk about Hepatitis Day and would try increase the awareness in the mass about hepatitis. But in 2010, World Health Assembly decided that no, let us not have different days, observed by different people and agencies as Hepatitis Day. It should be 28th of July. Then naturally the question comes, why so 28th July? And Baruch Samuel Bloomberg, who was the discoverer of hepatitis B virus, because it was not known till he discovered this, he used to actually observe 28th July because he himself was not sure. As in our country also, sometimes if you ask people, what is your date of birth? People do get confused because there will be something on the school leaving certificate, something the grandparents told the person as his or her date of birth. So similarly with Samuel, or better known as Bloomberg, so he used to observe 28th July as his birthday, and he's the discoverer of hepatitis B. He got the Nobel Prize. Interestingly, the day, just one day before 28th of July, that's 27th, and it's ORS Day, Oral Rehydration Solution Day, and very few are aware of it, and we'll try see why do we need to be aware about the importance of safe water, not just safe injecting or safe blood transfusion. So we'll get into the details of all of these, but I welcome all of you on this, on this occasion, Hepatitis Day, which is tomorrow, and Path actually has come up with this big idea, and this the next 1 hour or so, it's going to be fascinating in the sense I can see there has been huge amount of interest and people have registered, started registering, getting themselves registered for quite some time ago. And then today they have all assembled and have connected virtually. We have a galaxy of panelists, as you can see. So without much ado and without eating up on the most valuable time that we are going to, enjoy and learn from each other and exchange our ideas, I will go to Dr. Pauline Chan. But before we go there, so each of the panelists would get 1 question, and I request them to ponder upon that for 2 to 3 minutes, not more than that, because we are going to come back to that panelist once again. And while a panelist is talking about a particular issue or reflecting upon an issue, there could be questions, typed by the audience in the chat box. And I would request Saravana and Kannan from Path to identify if there is something which needs to be dealt with immediately. And before the question is posed to one panelist, there will be a little introduction, which will be about the panelist, which will be done from the Path end. And that's how we'll proceed. We have seen this slide. We do not want to see this slide anymore. Asha did talk about me. So we'll move on to the slide where we'll try know about Pauline. And Saravana, is it going to be you or Kannan? If you could kindly introduce.
Yes, yes. Thank you, sir. So, Dr. Pauline is well known for her work on infectious diseases, and then she's a consistent advocate for triple elimination agenda like HIV, hepatitis, and syphilis in the region. And then she's extensively worked in the Western Pacific region on hepatitis work, and she's currently working as a communicative disease lead with the WHO India office and working with 2 national programs, National Viral Hepatitis and National AIDS Control programs. Go to Dr. Pauline. Welcome to have you on this webinar.
Thank you very much, Kannan, and wonderful to see you, Samiran.
Same here, Pauline. I mean, it's always so much light and hope, particularly today, because the way Kannan introduced you, he did talk about elimination of 3 diseases, particularly with regard to the mother-to-child transmission, and it's about HIV, syphilis, and hepatitis B. So now the audience is looking at you as a ray of hope, and we are talking about the elimination of not just 1 disease, it's about 3 diseases, and that too, again, around the issue of mother-to-child transmission. So, Pauline, if I may ask you that you have, huge experience of working in various countries, and particularly in Southeast Asia. And then there is always, on the need for linking effectively the testing and the treatment. And of course, prevention comes when we talk about vaccination. In hepatitis, of course, we do not have vaccines for all the hepatitis causing viruses, but reflecting upon your experiences, what would you underline as the area for strengthening? If we think of testing and treatment on one hand, because once the testing is done and there is a need for treatment, that's on one hand, and on the other hand, about the prevention. And how do you see the countries in South Asia progressing in that direction, and what more could be done to strengthen or to plug in the gaps, whatever are existing? Pauline.
Thank you, Samiran, and thank you to all who have logged in for this webinar. Just as a basis, last year in the 75th World Health Assembly, all the member states, including India and all the countries in this region, in the Southeast Asia region, all 11 of them, voted to endorse the Global Health Sector Strategy for the next several years, up to 2030. And uniquely for this global health sector strategy, it draws the framework for integrated disease programming for HIV, for viral hepatitis, and for STIs. So there's a common framework to all three diseases, but also the disease-specific uniqueness of each one, because there are multiple diseases. But here in the South Asia, there are several overarching priorities for WHO. The first amount is data. Hepatitis is fairly new. STIs, even probably less data. And HIV is probably the strongest programming that we have so far because of the investment of the last almost 3 decades. But the first thing is to have the data and just to understand where we are in terms of hepatitis, of HIV, and also for STIs. The second part is actually about convergence. In every country in the world, and after COVID-19, we now know we cannot no longer have siloed way of single diseases. When people go to the clinics, they're looking for comprehensive care because a person can have diabetes, hypertension, can have hepatitis, or can have HIV as well, and TB. So one person should be able to get the access to any kind of disease that they have during their lifetime. So this convergence of health delivery is really important, particularly where people live the closest, which is primary care. And many countries are now investing in universal health coverage and primary care. And that would be the direction to go in the next several years up to 2030. I would like to also talk about viral hepatitis response. After COVID-19, we have to build back. In fact, we need to build forwards better. And what does that mean? That means that now almost every country in the world, every country in South Asia is investing in UHC, is investing in health insurance, is investing in, well, the National Health Mission is moving forward. The Pradhan Mantri Samagra Swasthya Mission is being renamed. For India, will probably lay down the foundations of moving forwards and advancing health delivery in the next several years. And what does it mean for this decentralization and integrated services for prevention, for testing, and for treatment? Rightly, what you said, Samiran, is just not one disease. It's really about multiple conditions, and hepatitis needs the delivery of several different health programs and optimizing this delivery through the National AIDS Control Program, NCD, the Cancer Program, the Maternal Child Program, immunization and achieving high hepatitis B immunization, especially the hepatitis B timely birth dose. And these are part and parcel of getting to elimination of viral hepatitis by 2030. But what is also important is the anchor. Our anchor in local solutions, but our anchor in greater and engagement, meaningful engagement with communities and civil society. Because we need to talk to the ground, talk to people who are affected, and we need to work on reducing stigma, discrimination that are barriers of access and barriers to testing as well. At the end, there are several very key approaches for getting to all the 3 diseases. The first is actually around triple elimination of mother-to-child transmission of HIV, of syphilis, or hepatitis B. These are blood-borne. You take a blood test, you test, and if the woman is affected, they can get disease-specific interventions. And why? Triple elimination of vertical transmission means that it will impact the next generation of South Asia, of India, of Nepal, of Bangladesh, of Myanmar. The new generation no longer needs to be viewed with chronic infections of these kinds. So I would say there is much to be done, and we look forward to working with everyone on this. Thank you.
Thank you, Pauline. That was excellent. I mean, you actually ran a thread through the flowers, and you insisted upon not looking at the flowers as isolated flowers, but the necessity of looking at the garland. Garland in terms of the solution. The solution cannot come if we look at each infection or disease separately or in silos. That's one very, very important point you made. Moreover, you not only underline the importance of this discussion and the approach that we need to consider or ponder upon in terms of the present generation, but the next generation. And you did touch upon the necessity for the funding commitment for integration of the programs, and most importantly, having our ears on the ground to the community and listening to the community voices and the concerns. Very, very important points that you have made. So I'll come back to you again, and thanks for making these points right at the beginning, which actually sets the tone very well. And how does the healthcare system at the primary care level need to consider all of these together, the diseases and also the mother-to-child transmission. But when we talk about mother-to-child transmission, not just the MTCT program, but the other programs, maybe non-communicable disease, maybe the program for the cancer, how do they integrate? What is the interface? Drawing upon where you kind of left in terms of listening to the community, I will now move on to Abu, a great friend of ours, who is there. And I will request Parth to introduce Abu first before I pose my question or the thought for him to reflect upon.
Thank you, sir. Thank you for that. Abu Mayer is well known as a strong community advocate of drug users and their issues. He's a member of working group for drafting National Viral Hepatitis Prevention and Treatment Guideline in India. He's currently the president of Injecting Drug Users Forum and a chair of Network of Asian People Who Use Drugs. Abu, over to you.
Thank you. I will not use my video because the link over here is a little bit weak. I'm honored and humbled to be present and give the community perspective on viral hepatitis.
All right, Abu, thank you. Thank you, first of all, for joining. And it's okay. If the video cannot be switched on, it's okay. So, Abu, yeah. I'm really honored and pleased because, you are not only because you are a great friend of mine, because meeting friends always brings pleasure, but you come with a rich experience of working with the community. So my question to you has two components. One, do you think that there is enough awareness or adequate awareness amongst the community members around hepatitis B? And if not, meaning if there are gaps for whatever reason, would you please elaborate upon that and how do we try plug this gap? And the second component of my question is, how do you see the government program running, not from the government lenses, but as it gets translated on ground in the community? So these are the two questions which I would request you to reflect upon. Abu, the floor is yours.
Thank you very much, Dr. Panda, for your question on the community perspective on awareness. As we all know, with the data available, it is very clear that the people are not coming forward for diagnosis or for testing. The data, if we see the research data, scientific research data from IBBA or from sentinel surveillance or any other scientific study conducted or privately conducted, the disease burden shows is very high. But however, the actual in the national program who has come forward for testing or diagnostic and treatment is very low. So therefore, I can say that there are very less awareness among the community, especially the key population. What we have seen at the state level is that there is no investment from the national program to generate awareness among the key population and other population. Some might argue that they have provided some investment, but as a community, we have not seen any investment or have received any investment in most of the states. And if from the central government, if they are providing and the state government is providing in the state, then we have to evaluate ourselves or evaluate the messages, how it is going out. Either the messages are appropriate, are effective, which community can understand or will have impact among the communities who can be motivated to go for testing and treatment. So right now, I have not seen many IAC materials from the state perspective or national perspective, or even in Asia regional. There are few IAC materials floating around in the social media time to time, but those are not effective. So I should say, I can say that the awareness among the community is very low. Thank you. And what is your next question, please?
For the next question, I'm going to come back, but because you have touched upon a very, very important issue, and I do not want to lose on this. You said, Abu, clearly that messages are going out as part of the government program, but are they being understood, or are they able to serve the purpose they are intended to serve? So it reminds all of us here, not just the panelists, but the audience, that we do communicate, but do we get communicated? There's a difference. We might speak, we might do things, we might have billboards, posters, and we might think that, okay, there is a tick on my program list. As Abu said, the programs and the messages go out, but are they reaching out is the question, number one. And number two, then Abu said, the information IEC, if that is supposed to encourage people to take up the test and then treatment, if the need be, is that happening? And he has reasons to believe, and based on data he's saying, so naturally evidence speaks, right? The data speaks. It's not just subjective opinion that Abu came up with. And he said that the data clearly underlines that the test uptake and the treatments are not reaching the extent it should have reached. So maybe we are failing somewhere in terms of strategic communication. If the communication needs to be strategic in nature, with a defined purpose, that's not happening. Thank you, Abu, for highlighting this. And I am reading the questions which are there in the chat box. I will pick them up as well as appropriate. But right now I can see that there is a question in terms of change in the prevalence of hepatitis and maybe specific viral infections here. Whoever typed that meant that. And if there are other questions, we are requesting, the audience to put them in the chat box. But right now, the questions that has come out from or up from the audience is that, are we seeing the changes in the prevalence? So with that, I will go, that's a very technical question. And so I will naturally go to my next, not only professional colleague, but a personal friend, Dr. Umesh. I meet him these days more through screens rather than physically. Hope to meet him physically at some point in time. Yes, Kanan, if you could kindly introduce Dr. Umesh.
Thank you, sir.
Yes.
So It is like Dr. Umesh is a very passionate public health and development professional and majorly working on the communicable disease in multi-country settings who has some experiences, and he is leading the key populations portfolio with community engagement with the CHAI, and also he is working with National Viral Hepatitis Program and also NACP program for quite a period of time. Thank you, Umesh, for joining with us.
Thank you very much. Thank you, Dr. Panda, for your very lovely introduction. And I'm extremely humbled with the amount of people that have joined this webinar today. Over back to you, Dr. Panda.
Thanks, Umesh, for joining us. And we will start from where Abu left. And the question that popped up in the chat box. The question was about, Abu did talk about data. And the data indicating something. Now, you have this huge experience of working in several countries in this region. When I say region, South Asia and Southeast Asia. And then in the country again, it's not a homogeneous, uniform epidemic. So maybe it's endemic in some state, epidemic somewhere else. So my questions are basically two. One, do we see the change in prevalences within India and in the region? And if so, if we are experiencing that, what could be the reasons? So that's one. And what have been the efforts to do the monitoring in terms of the change in prevalence or the tracking, the transmission of the infections, viral infections we are talking about here, which lead to hepatitis? So Umesh, the floor is yours. The emphasis is on the programmatic evidence generation through surveillance. And are we seeing change in prevalence? And if we are not able to catch that or capture that, why so? So I'm basically asking a very specific programmatic technical question. And what would be, from your experience, your suggestion to improve upon this so that we know how the beast is really?
Thank you, sir. I'll break your question and I'll answer the second one first and then go on to the bigger question with regards to change in prevalence or perhaps increase or decrease of incidence. In my point of view, I think viral hepatitis programming is very new. And I'm talking in very clear context for low and middle income countries. The hepatitis programming in quite a few countries have not even begun. And in some countries within the LMIC bracket, such as India, Egypt, Rwanda, Georgia, they are much advanced as compared to other countries in sub-Saharan Africa, in other parts of Africa, Southeast Asia, where countries are just now rolling in the thought of they need to start providing hepatitis services, not only for C, but also for B, which is now becoming a bigger concern because of much more information that is coming in. The management information system or the data collection information system are therefore equally nascent in nature. And thereby, the kind of data that we get, which is under routine program and routine monitoring data, continues to remain rather very small and very precise and does not give the granularity for us to identify the patterns of infection. I'll give you an example. For example, most of the MI systems that I'm aware of and have been working with in many of these countries do not segregate data by key populations, do not segregate data by priority populations. And as Dr. Polin Chan had mentioned, you have a very, very strong strategy that is available internationally, which categorically says identify your priority population first, identify your key populations first, which often tend to have a higher prevalence, which are unlikely to meet or get health services, and thereby require you to be more focused on them. However, if you look at routine monitoring data from most of these countries, we will not be able to differentiate who are we covering and what is the outcome of that coverage. So there's a very, very big problem. However, because most of these countries are starting their programs, this is an opportune time for us as communities, as stakeholders, to guide many of these countries towards a stronger management information system for viral hepatitis, and keep in very key considerations of their program needs, the WHO guidelines, and what kind of data is required by the program. Look at it as a starting point, because we are aiming at elimination by 2030, and one of the biggest parameters that are required is the kind of data that you need to establish that you are going to eliminate, or you are moving towards elimination. And last but not the least, there is a major gap with regards to how many stakeholders are going to enter data. For example, in the country of India, there is no provision for private sector to enter data. There is no provision for perhaps even NGOs and civil society who are providing services outside the public, the National Viral Hepatitis Program, don't have any avenue to provide data. So therefore, there's this major routine data gap, and thereby it does not really inform where the epidemic is going. It does not really inform who are we reaching out to and what are the results to that. I have to put it out here saying that irrespective of the kind of data that is available, it is not publicly available. We are not party to any kind of data at the country or the regional level. So for us to make, informed thoughts or informed strategies per se, that data remains pretty hidden in very closed quarters, and it's not that easily available. And to some extent, I would have to put WHO on the spot on this also. We get only the regional as well as the global hepatitis report once in 2 years, and often 2 years too late. So the latest one that we refer to is a report that is of data from 2019, which we got in 2022. And for the data that report is going to come up by the end of this year, essentially puts information only till progress made till 2021. And I think we need to keep up with the times and get more data available for all of us to be informed as to where the epidemic is going. In clear relation to surveillance and overall epidemiology, there is frankly nothing special that you need to do for hepatitis. It's like any other infectious disease. However, the interest as well as the resources that are going into understanding the disease pattern and understanding what is happening is very, very low. It's very less. Quite a few countries have done their integrated biological and behavioral surveys. The information is not available to us. Many countries do have routine surveillance, and unfortunately, that data does not really come out publicly. And I'm not very sure how that data is also being used for programming purposes. I do realize we have very little time, so I'll stop here and give it back to you.
Thank you. Thank you, Umesh. Again, I cannot thank you enough, because you did talk about making sense of the data which is available and the challenges associated with it. So somebody said water. I mean, I'm sure you know that it was Thomas Coleridge, that water everywhere, not a drop to drink, while he was sailing on the ocean. It's so salty, you cannot drink it. So drawing upon that, one could probably say data everywhere, but not a meaningful chunk to use. So making sense of the data and making of the sense of the data requires knowing how the data is being collected, how robust the data is, has it been cleaned, which population group is it, reflecting or representing, and then trying to make sense in terms of informing the program. The second point that you talked about is data access. Even if there is data, sometimes it so happens that it is not available in the public domain. And then naturally the question comes, what does it mean and how do we inform the program? But the last bit that you said is so very important. You did talk about the necessity or need for not only knowing how is the virus spreading, but the need for running with the virus, or if not ahead of it. But what is happening now is that we are running behind. The virus has turned out to be much smarter. So it is making its new inroads, and we do not know where is it making, head forward. So it is so very important to strengthen the surveillance in order to know where is it going. That is exactly the phrase you used. And in order to know where is it going, we have to run with it in order to see where is it going, so that I can one day move ahead of it so that I can stop its spread. I will come back to you, Umesh. Now, you did talk about where from the data is coming and which population represents. So I go back to now the population representative huge experience that Yashvinder, you have here amongst us as one of the panelists. I'm sure everybody would benefit by listening to Yashvinder. But before we listen to Yashvinder, I will request Saravana to introduce Yashvinder.
Thank you so much, sir. So Yashvinder is known as the community activist, and she is passionate filmmaker. And she continued to advocate for the rights of the LGBTQA++. And she is the member of NVHCP steering committee. And she is currently working for the viral hepatitis program in Punjab and Haryana through CHAI. So over to you, Yashvinder Singh.
Thank you. Thank you very much. Hello, everyone, to all the panelists. And thank you, Parth, for organizing this wonderful discussion, because I think this is the need of an hour. This is the time to kind of, break the silence for a disease which is a silent killer. This is how I would like to start. And I think we are not waiting for sure. So you know that, and I think this is an opportunity for me kind of, where we can, I love to talk more about, as you said, about communities and how the progress has happened so far. So over to you, Dr. Panda, and really love to see you after a long time.
It is always a lovely experience has been there, coming across you, be it virtually through screen and hopefully someday physically. So coming back to the phrase that Yashvinder used, a silent killer. So the silence comes from what actually Umesh said and Pauline touched upon. And of course, Abu also mentioned about the lack of adequate awareness about the infection. So silent spread happens when there is not much known. Yashvinder, I would request you to reflect upon the need of the MSM and transgender community around hepatitis. But at the time, while you will be doing that, do you see an opportunity to draw upon the lessons learned from HIV? And how could we get helped in terms of our planning, activities, interventions based on the learning that has happened, if there are good practices and you think that it's high time we do that? Your reflections, please.
Thank you, Dr. Panda. I think, this is how, we know that all the panelists have spoken about, especially Abu, Pauline, and Umesh. We know that, it's relatively a new program, and comparing it with some very well-established program would not be the right thing, but there are few learnings which I think right in the beginning of the program, we talked about NVSCP when it was launched and prior to its launching. I think first and foremost step was engagement of the communities in planning of the program. I think that is really a milestone, I would say, because that helped us to kind of, communicate our concerns and suggest to the program, that what communities need. Although we know that in 2019 and 2021 almost gone into COVID, and we know that all the health programs have suffered because of COVID, and so NVSCP program as well. I started with saying, it's a silent killer, and I'm really sad to see that there is a more silence about, people don't talk about hepatitis at all. So we know that, in HIV program, for example, when communities came, it was all the, stakeholders who started talking about, HIV. Only then, more and more we will talk, I think will help us to kind of mainstream the issues. As Abu said, communities don't have much idea. They do know about STIs, they do have understanding about HIV, a little bit about TB, but about hepatitis, I'm sorry to say it's relatively much lesser as, we are expecting it to be. So I think that is the first thing that we need to definitely talk about it. Now, how to talk? National program definitely, acknowledges the vulnerability of communities, but at national level, we don't have data. We don't have any data which is actually talking about that who all are vulnerable, whether drug users are only vulnerable or a transgender woman is vulnerable. We really don't know about that. Now, what it does, it creates an arbitrary, kind of a feeling where we start kind of labeling certain communities. Okay, hepatitis C, it's only PWIDs. When we create this sort of feeling, then we are actually depriving the right of all other people who are vulnerable and who are pushed back onto a corner. I think that is one thing we need to really focus and really, shun. And we do have an example from HIV program. I know that, when 80s it came, it used to be gay man disease. Then in India, we used to say, oh, it's only for truckers. Oh, it's only for this population, that population. But we know that. And then everybody's getting impacted by this. And I'm sorry, in Punjab, for example, state like Punjab, which is having a very high burden of Hep C, it is even showing very high positivity among general population. So we see the similar trend, this is how infection flows. So what we have to kind of, do first, we need to have a very specific IC material, each typology wise, because that's how the HIV program was able to build a connect with communities. Why I'm saying so, because if I'm a transgender woman who is on HRT treatment, hormone therapy, should I take this pill? What are my risk factors? I need to be aware about it. And we have seen that in COVID, when COVID came, people who are on ARV drugs, they thought somewhere, that, okay, they are already on COVID. So, on ARV, which is antiviral, so COVID may not affect them. This is how, these are the myths we need to kind of, break and demystify it, And I think last and not the least is, I think supply side, definitely we need to provide, opportunity to the community where communities necessarily, not opening only one window, but multiple channels, whether a person want to take services under NVHCP or under Sampoon Suraksha or in TA or in other sort of arrangement. I think that should be made available. And also we need to bring some innovative technologies. For example, we know innovative tools like self-testing is one of the things which we talk about, I think those kind of things will definitely help us to kind of, expand our reach, because right now we really don't have data of the disease and how it progresses within the community and each type of typology or subtopology wise. I would like to end in the positive time by saying that we also need to build the synergies, because we know that there is a strong component of community system strengthening under CLM, which is community led monitoring, where under NACO have approximately more than 12 key population representative in each of the district of India. So 700 district into 12,000, 8,000 people are there. Somehow we need to kind of build synergy. Somehow we need to engage these key populations into the program so that we can leverage their services and we can help to deliver the message to the communities, which will eventually help in demand generation. I would love to talk more about it, and I know I'll come back definitely, maybe next question. So over to you, Dr. Panda.
Thank you. I do not have enough words, because not just I'm a researcher, and you did talk about innovative HIV self-test, hepatitis C self-test, and the need for having them in the program, and also the need for addressing the myths and misconceptions around if you are on a particular medication that to take care of your COVID. So those are all very important. But where did my heart go, when I was listening to you? You talked about vulnerability and using the vulnerability as a tool or means to label as if the vulnerability is vulnerability to hepatitis. We are talking about hepatitis here, is there in with certain groups and in certain regions. But is it really so? Because now we know that with the practices in the even quote unquote general community, the hepatitis C outbreak, can happen, and that's what we saw, witnessed in one of the states in the northern India. So it's not about PWID alone or MSM or transgender, and you underlined it so very well, because we are talking about particularly hepatitis C, which is so transmission efficient that you don't need to have a particular risk practice to be vulnerable. So if we are not careful about our practices in the community, quote unquote, general community, we are all vulnerable. So how do we change our narrative? I will bring these issues with Dr. King, who is our next panelist, to whom I will turn to. But before I do that, I'll request Path. Rajiv, I appreciate that you introduced Yashvinder, who is going to introduce Dr. Keen now from your end.
Yeah, thank you, sir. So, Dr. Kim is a well-established researcher on liver diseases and vaccines, and she has been working with the government systems for last 3 decades, and she has been active member of WHO's Sierra Office TAC Committee for HIV, STI, and syphilis, and she's currently working as the president of Myanmar Liver Foundation. And happy to have you, Doctor, on this very important webinar from Myanmar. Thank you. Dr. Yoda, yeah.
Thank you for the kind introduction. I'm very honored to give this presentation on this auspicious occasion. Over to you, Dr. Panda.
Thank you, Dr. King. Now, I know that you have something very exciting, to share with the larger audience. But I was also reading, the previous question about changing prevalence that Umesh and others, Dr. Umesh Chawla and others addressed, is about around a question that was raised by Kabil and Nannadurai. But there was another question, and while I was reading it, I thought that I would put that up to you while you'll be reflecting upon the Myanmar is not waiting for sure in terms of hepatitis. But while you'll be reflecting, Dr. Kane, I would request you also to respond to this question, which has been raised by Dr. Rajat Adhikari of WHO, if I'm not wrong. Why funders are hesitant to put their money on hepatitis? As of now, very few of them committed to it. Please enlighten us on this. So Dr. Adhikari probably is talking about the funders and their commitment in different countries. But as I realize that in Myanmar, there is a commitment. So how did you have this advocacy or this commitment for funding? Because if you say that Myanmar is not waiting, I'm sure that something exciting is happening out there. So my request to you, Dr. Kin, is to tell us what is happening in Myanmar, so exciting in terms of not waiting and doing something about hepatitis, and how could you address this issue of funding or lack of funding or paucity of funding not becoming a problem? How did you overcome that challenge? Dr. Ken, the floor is yours.
Thank you for the question. Actually, we are always worried about the funding, especially because we are working on viral hepatitis. And as you know, the funding for hepatitis has almost no international funding. So the main funding in Myanmar by the Global Fund and other international funders is for malaria, HIV, and TB. And the authorities who are in charge, these 3 diseases are also the important diseases in Myanmar, and their importance exceeds that of viral hepatitis. So as you know, viral hepatitis has no international funding, and for for our patients to be treated, we have to piggyback on the platform of HIV because there's only funding for co-infections, HIV co-infections, which is with hepatitis B or C. So usually hepatitis C, most of our funders, they fund for co-infections of HIV with hepatitis C. So Myanmar, as you know, is deeply plagued by the tuberculosis up to now. Malaria is going down and HIV is also going down. But even now, these three diseases are considered as the three most important diseases, far exceeding viral hepatitis. But because we are working on viral hepatitis, the prevalence is quite high. The prevalence of viral hepatitis in Myanmar is according to the National Serial Survey carried out on 2015, hepatitis B is 6.5% and hepatitis C is 2.7%. So it is quite high. And the incidence of cellular carcinoma, cirrhosis are also very high in my country. So, but thankfully, both the public and the private sectors work in collaboration for the prevention, control, and treatment of viral hepatitis. So the National Hepatitis Control Program was initiated not so long ago. It was initiated in 2014, according to the recommendations by the World Health Organization. And since 2017, the National Simplified Treatment Guidelines for hepatitis B and C were carried out by the hepatologists with support from the World Health Organization and CHA. And they have been distributed to the general practitioners all over the country. This is because in Myanmar, general practitioners are encouraged to treat uncomplicated cases of hepatitis B and C patients. The hepatologists, they also visit major towns across the country to give health education talks and training to treat the chronic hepatitis, viral hepatitis patients, and also act as training of trainers. So, like you said, like you recommended, in Myanmar, we are joining hands to combat viral hepatitis. So in Myanmar, the National Strategic Plan and also the Myanmar National Action Plan is in line with the Global Health Sector Strategy, with focus on the universal health coverage and the continuum of hepatitis services with public health approach. In 2017, milestone for the National Hepatitis Control Program as the first public sector hepatitis C treatment program was launched using highly effective TAA drugs, the generic drugs, at 12 treatment facilities across the country from 2017 to 2020 in over 6,000 patients. And the overall SVR12 achievement at that time was 91.4%, so it was quite satisfactory. However, the program was halted in 2020 due to the COVID-19 pandemic, followed by the civil unrest in the country. Otherwise, it was planned to extend the number of patients, and also every year, at least 2,000 patients will be treated free of charge, with investigations also free of charge. So this is for hepatitis C. For hepatitis B, emphasis was placed on the prevention according to the national policy by including 3 doses of hepatitis B vaccine in the EPI program and for the newborns also. So this has been carried out since 2003 throughout the country. Hepatitis B vaccine is also applied to high-risk groups and special population groups such as healthcare workers, pregnant mothers, PWITs, and family members of hepatitis B patients. And this is also carried out by the not only by the EPI program, but also by the private sector, the NGOs, INGOs, and civil society groups, to also give health education talks, uh, screening for hepatitis B and C in the community, treatment for hepatitis B and C, vaccinations, and as research projects or service projects free of charge or at a discount rate or on a cost sharing basis.
Okay.
The private sector organizations for hepatitis such as Human Liver Foundation and GI and Liver Society, we hold commemoration ceremonies for World Hepatitis Day every year since 2012. The National Hepatitis Control Program also organized World Hepatitis ceremonies since 2017, 18, and 2019.
Got it. So, Dr. Kin, as I can understand that I see a political commitment, number one, in the country, not much dependence on the external funding. Thirdly, it is not just the so-called known vulnerable groups, as Yashvinder underlined, but to reach out to expanded, population where there is an interface, the family members of those who have been identified, and ensuring, above all, the treatment. Excellent. And you talked about recognizing the problem, because you said that the problem is quite big in some groups, and so recognizing that is so very important, which remains at the center of any effective intervention. Maybe we'll come back to each of the panelists, but before we do so, we will go to a great friend of mine and a person with huge experience of working in the community, Rajkumar Nilakanta. Introduction of him, please.
Thank you, sir. Rajkumar Nilakanta is a strong community advocate working for injecting drug users and the PLHAV community and the related units. He has also conducted viral hepatitis studies, particularly proving the strategy for a community-based strategies and on same-day initiation of hepatitis C treatment. So he is currently the president of CORE. Over to you, Rajkumar.
Good evening to all the panelists and participants as well. And thank you so much, Spark, for organizing such a wonderful webinar. And thank you for inviting me as one of the panelists in this webinar. I look forward for my questions from Dr. Panda. Over to you, Dr. Panda.
Right. Thank you, Kanta. As you are better known, we make a short and sweet name that we use for the friends we love and hold so dearly close to our heart. So, Kanta, actually, the question that I want to pose is from the work that you are so much interested in, and particularly in terms of the thing that is happening in terms of same-day treatment. So if you could elaborate upon that, because many of the panelists have underlined the disconnect between the test and the treatment, and then how quickly you get more and more people under treatment. So if you could kindly elaborate on that concept, please. The floor is yours.
Thank you so much, Dr. Panda, for the question. The model that you have been asking was one of the initiatives that we have conducted in Manipur with a lot of enthusiasm. See, some of the reasons or factors, I should say, that inspire or motivate us to come up with an idea of same-day test and treat is that in the hepatitis C care cascade that we are maintaining since 2014, we observe a huge gap in patient follow-up in two different stages. The first test is in between the number of people tested antibody positive and the number of people undergone RNA test. And the second stage is in between the number of people confirmed RNA positive and number of people initiated treatment. And on the other hand, we have national program, and the national program testing and treatment are available free of cost. However, the uptake of hepatitis C care is very poor due to the lengthy pre-treatment process. So such situation compel us, to develop a model of same-day hepatitis C screening, diagnosis, and treatment among people who inject drug as a replicable model. This initiative was a public-private partnership with the involvement of National Viral Hepatitis Control Program, FIND, Treat Asia, Babina Diagnostic, without which this would not have been possible. So going on to how we have done this in terms of the method that we are involved. We work with the drug treatment center, targeting people who use drug undergoing drug treatment. We provide on-site rapid diagnostic tests for hepatitis C antibody test. The blood sample for those participants tested hepatitis C antibody tests were collected and transported to Babina Diagnostic, where hepatitis C RNA test was done using TrueNet MolBio. Those participants who were RNA positive confirmed were initiated treatment on the same day with the advice from the doctor at the Model Treatment Center, Jawaharlal Nehru Institute of Medical Science, as per the guideline of the national program. So in 70 days between November 21 and January 22, we conducted 23 screening camp in 22 locations where we were able to screen 523 people, of which 259, 49% were found to be antibody reactive. 100% of them undertook RNA tests on the same day. 167 out of this 259, which is 64.5% of them were confirmed to be RNA positive. Out of this 167, 99.4% of the people were initiated treatment on the same day. 88.7 among those initiated treatment achieved SBR 12 week. So in terms of the time that we are involved in the process, starting from screening till the initiation of treatment, the median time that was taken were around 6 hours 49 minutes, with a minimum time recorded as 4 hours 36 minutes and maximum time recorded as 12 hours 18 minutes. Here, I would like to note that we can decrease this minimum and maximum time to at least another 40 to 50%. This time, the median time was little longer because we were allotted and we used only one extractor. If we utilized 2 extractors of the MolBio machine, then the median time would have come down to at least 50%. There was a limitation in terms of the availability of the infrastructure that made the median time little longer. So this was how we done. I will be happy to answer if there is any questions.
Kudos to you. I do not have, enough. I mean, I'm sure that my feeling is shared by everybody here, particularly when you talked about the median time between the test and
Yes.
putting somebody on treatment. I mean, this is like a dream thing for each one of us who are connected here, I'm sure. So you actually got us to a final culmination. We did talk about the problem and how to improve upon that, and the need for understanding the community, listening to the community voices, and then actually reaching out to the community and closing the gap between the test and the treatment. I did read the questions, which I requested the audience to raise in the chat box. I will request them again to do so, but my request now to each of the panelists would be to come up with one last message, which cannot be more than half a minute. But I mean, I'm not pushing you, but what I'm saying that we did go through a fantastic, reflections of thoughts, and then the linkages that we saw having, taking place on the ground, and then the treatment-related issues, the vulnerability, and the labeling, which could be detrimental for a program. So keeping all these in your mind, and whatever you have been able to listen to, if you could have your one sentence reflection, wisdom, something that you wish to share with the audience. But before I do so, I'm not saying, I will request Path if they could see any other new question coming up in the chat box, because we are not going to do it one-on-one. There could be a question from your team as well, Path. So feel free to ask that question if you want to do so orally, or if you see any other question getting typed in the chat box, please read it out. I cannot hear anything from Path. Do you have any question from any of the members?
Sir, there are questions in the chat box which I've shared with you. Like one of the question, which I remember, is about the whether hepatitis C could be introduced in the de-addiction facilities or the OST facilities. Is that going to be helpful for hepatitis C testing and treatment uptake? Is one of the question which is related to our task.
Okay, so for that, I will go straight to Abu. Abu, what's your reflection on that? So your one sentence on, can the hepatitis C test or should it be done? To both Abu and Nilakanta to reflect upon. So Abu, your one sentence first. Should we? Go ahead.
Yeah, we should. That because we are, as I said in the earlier part, I missed in the middle because of the link. But when I talk about the IC things, but we have missed the target group. The IC thing also has not reached the target. Now testing also is not reaching to the target group. Therefore, in OST center or any drop-in center, the target groups comes over there. The high-risk group, the key population comes over there. So that is an opportunity. And I believe the National Viral Hepatitis Program and NECO is working on the formality and SOP in regard to integration. So I hope and pray that National Program for Control Program for Viral Hepatitis and NECO made able to come up with that strategy. Thank you.
All right. Thank you, Abu. What I hear is a resounding yes, that we have to reach out to the addiction treatment centers with the hepatitis C testing and treatment service. Now, if I could go to Kanta, whether OST services, oral substitution treatment or therapy services, should it be integrated with hepatitis C interventions or services? Nilakanta,
Yes. See, OST side. Because earlier we have requested our nodal officer many a time to start collaborating with Ministry of Social Justice and Empowerment, Social Welfare Department. Most of the time, National Viral Hepatitis Control Program is trying to collaborate with NACO only. They are always leaving behind a large number of drug users who are undergoing drug treatment under Ministry of Social Justice and Empowerment. See, in the context of Manipur, the drug treatment duration is 3 months. At the same time, hepatitis C treatment duration is also 84 days. So drug treatment is one of the best sites, I should say, to identify for initiation of Hep C treatment among people who inject drug. And also, OST site is also one of the hotspots that we identified for organizing hepatitis C screening camp, because drug treatment center is a closed setting where all the inmates will be there for the entire 3 months. Similarly, OST site is also one place where patients are visiting or coming on a regular basis. So undertaking or testing or screening among them will help us to increase the uptake of Hep C treatment.
Thank you for that. I will add on that if somebody gets treated for hepatitis C and the person is a person who injects drugs, he or she might get reinfected with hepatitis C. So if he or she is on oral substitution therapy, so there is all probability, there is great possibility that he or she might not get back to injecting, risk-taking injection practices. So hepatitis C treatment once eliminates hepatitis C, but does not eliminate the chance of getting reinfected. And here comes the importance of oral substitution therapy. Yes, Binder, I can read the question that Sahil raised. The question that Nilakanta addressed was raised by Rajiv, but Sahil is asking, do you think behavioral change and communication has a role? Because you talked about it, Yasbinder. So behavioral change and communication, has it got a role in motivating the community to get screened for hepatitis? And if so, how can we as public health professionals leverage the behavior change, test uptake? How?
Yes, definitely. I think that is the learning which we also had seen. And if we all know that, in 1999, early 2000, even under the TIV, which is for HIV prevention, we used to talk a lot about IEPC, BCC. But now I think, when ARTs came, there was a less focus on that. But that is one tool which has actually, built that understanding within the community that, yeah, something which is dangerous for them is HIV and STIs. I think we definitely work on that. But to work on that, I think we need to have a committed funding, number one. Then we need to have innovative approaches which are tailor-made for the key population, because currently what is happening that the program, HIV/AIDS program is a very vertical program, but here it's a larger health program, where people may not be necessarily, sensitized to understand the community issues, and to sensitize them, it take a longer time. So meanwhile, to have an intervention where we reach to the communities and we provide services at their doorstep is going to be helpful. And last but not the least is, I think everything has to be very human-centric approach, because that is, I think, the core of all the interventions if we want to make it successful. Over to you,
Wow.
Dr.
Wow. Having people at the center of whatever we do is what Yasvinder is underlining. Dr. Umesh Chawla, there are questions raised by Rajat in the chat box, which is about even after so many years of the national program, why are we saying that we have limited data on viral hepatitis, hepatitis B, hepatitis C, and even the incidence data is not available, like sufficient data and the data of a kind that would be really helpful. So as you touched upon this very important issue, I'm not putting you on the spot or something, but would you have any suggestion, in this regard? Dr. Umesh, please.
I think Dr. Rajat's is a very pointed question that there is data, why is it not available? It's not about there is no data available. And to be very frank, I have no visibility of why the data is not available if it exists, and why is it being delayed so much. I really don't have any visibility on it, sir.
Okay, excellent. So actually, Dr. Umesh Chawla mentioned then what should be done. I mean, how do we increase the visibility of the data and the data from decentralized locations where the program innovations need to happen? Now, I see a question. If I'm not wrong, a friend of mine, I have so many friends all over the world, because that's what I feel is the meaning of life. Keto Angami. And Keto is asking, and this question is to Pauline. While the testing, diagnosis, followed by treatment for hepatitis B and hepatitis C is yet to be picked up in full gear, what is being missed out is the prevention. So unless the program stops new infection, he means incident infection, new infections, the spillover for treatment cases will keep accumulating and escalating. So he's bringing up a very, very important issue. Why is prevention not given equal importance as we feel comfortable about talking in relation to treatment? Pauline.
Thank you very much, Samiran. I think, and Kitten as well, because I think it's a very important discussion. I do think that with the excitement of the hepatitis C cure, globally, all countries onboarded very quickly on hepatitis C cure, and especially now, cure, it's a matter of $30 to $90 in very many countries. Of course, there will be some differences. But the more important part is on the prevention part. The prevention part hasn't had its spotlight, because actually prevention for both hepatitis B and C are very old health programs. And why? Prevention of Hep B, Hep C, it really is tenated on current activities. That is, for example, blood safety for bloodborne infections. That is HIV, syphilis, Hep C, and Hep B screening. Infection prevention and control, safe injection, sterilization, good dental care, safe tattooing, safe sterile tattooing. These are the things that infect both for B and C as well as for HIV. So they are common routes of transmission across all the bloodborne infections that are very basic to general health systems. Prevention of mother-to-child transmission. And that's why the flag of triple elimination of HIV, of syphilis, or hepatitis B but also hepatitis C mother-to-child transmission is actually quite important, particularly in the Northeast where Hep C is relatively high, and it can be also high in the general population, as Jashwinder said about Punjab, that is high in the general population, and pregnant women is a woman living in possibly a high background of C. So these are very basic things about prevention. Hep B immunization in India or in many of the countries have not achieved the high coverage rates that it should be. Hep B timely birth dose, where a baby receives Hep B vaccine within 24 hours of birth, is still quite low in the mid around 40% in the CRO region. Although the uptake of other coverage, the additional vaccines for Hep B is much higher because of the pentavalent vaccine. But even then, this is challenging because the first timely birth dose of vaccine is critical. I say critical for Hep B prevention of mother-to-child transmission. So there are some very basic things that we need to get not only implemented, but at very, very high coverage. And that means, and that's what elimination means, high coverage. It's not enough to put something on ground, but we have to scale it up to high coverage. And that's what elimination is.
Excellent. So what Pauline is saying that look beyond where the light is. It is easy to search for things where you have the light on, but probably we need to look beyond what are the different practices and what are the risks associated with contracting infection. But the advantage of having a fantastic panel like this is what, when they speak, they also address questions which I can read in the chat box, and somebody asked, Karthi, who is from Chennai, I guess, so I can have a chat with him when he invites me to go to Chennai. But he actually asked about what is the strategy and are the high risk community members being involved, getting engaged in every action. And so that's exactly what is the point. So coverage, if we want to have an adequate coverage, which would reduce the chance of transmission of infection, then we can really need to realign the program with the efficiency that is there in the community. So there is a question by Gitain, and if I'm not wrong, the Gitain, whom many of you know of, Dr. Kin is also in the panel. That's what Gitain is writing. We can also hear from her how Myanmar is doing catch-up vaccination among high-risk groups as a part of their national viral hepatitis plan. Given the social unrest in the country and all the other challenges. But what is the crux? Just in brief, you could tell us, Dr. Kin, how did you plan, or did Myanmar plan to catch up with the wide-scale vaccination? And of course, we are talking about hepatitis B vaccine here, I'm sure.
Yeah. We have a lot of high-risk groups in Myanmar. The healthcare workers, the PWITs, and the dialysis patients. Majority, the EPI group takes care of them, and also a lot of them are also taken up by the NGOs and INGOs. For example, Myanmar Liver Foundation, we have, because during our early years after formation of the Myanmar Liver Foundation, we concentrated on the prevention, giving health education, screening for BNC in the community free of charge, and also hepatitis B vaccination free of charge. We vaccinated a lot of people in the community, but also a lot of the high-risk groups like orphanages, nunneries, monasteries, where people are sort of institutionalized. So we carry out a lot of vaccinations in these patients. So also other NGOs and NGOs and the donors, a lot of donors on their birthdays or like celebrated other occasions like their anniversaries. So during these days, they donate money to buy vaccines for a certain group of people, like monasteries or nuns, monks or nuns. So we do a lot of that. So during the first about 6 years, we concentrated on that, and we were able to immunize 3 doses of hepatitis B vaccine to more than 500,000 subjects, people. So, so that was our by Multilateral Foundation alone. So other foundations and other NGOs and INGOs, they also do these vaccinations, a lot of these vaccinations. We carry out the vaccinations also on the healthcare workers. So the National Hepatitis Control Program, with support from the EPI program, they also carry out these vaccinations in the high-risk groups. Also for the PWITs also.
All right, excellent. So we can learn from each other. So Myanmar has thought through, and the neighboring countries can all draw upon those programmatic elements. Before I come to the end of this program, I have two things to be mentioned to PATH team. One is asking about if somebody is, is a person who injects drugs and is living with HIV and is on treatment, and at the same time, he or she realizes that he or she has been infected with hepatitis C, what should be the investigation workup and the algorithm and the treatment modalities. So these are the probably, path to follow the future path. You know what I mean? So the path should try help out on these paths of inquiry. And Anushree asked something which is again very, very interesting, and that's probably an indication for path. When we sort of, used to call up somebody during COVID time, there would be a message around COVID. And Anushree is saying that can we not advocate with the government and the telecom service providers to run messages on hepatitis as they did for COVID? And that's again another very important, indication or innovation that someone is talking about. Many more questions about funding in order to strengthen the strategic communication, and a topic like hepatitis, because when we say hepatitis, it's one word, but if we think of the viruses, minimum 5, and I'm telling you, it's much more than that. So, and running 22 minutes over the scheduled time is nothing, I would say, because 1 hour cannot do justice to a set of viruses, which is 5 in number, minimum 5, and there are other viruses which can also give rise to hepatitis. I hand this over to Saravana for the final vote of thanks and the concluding comments or the remarks, if you have any.
Thank you very much, sir. So just before going to the vote of thanks, I would like to request all the panel members to switch on the cameras so that we can have a photograph together as a mark of this webinar. Abu, is it possible to switch on your cam? Abu, can you hear us? Okay.
Yeah, hello.
Yeah, can you switch on your cam for a minute? We can have a picture together.
Yeah.
Thanks. Thank you very much. Yeah.
Okay.
Okay. So thank you, sir. Thank you. I need to thank each and every one of you. Like on behalf of PATH team, I would sincerely thank for all the panel members who have been here with us as a mark of this World Hepatitis Day and joining hands together to act against hepatitis in South Asia. So, and we would like to, as an outset, we would like to express my sincere thanks and gratitude to Dr. Panda, who has agreed and moderating this session with a great zeal and inspiring with his thoughtful words as always. So thanks for that, sir. And I also extend my thanks and gratitude to Dr. Pauline Chan, who has been encouraging and motivating not only for this webinar, in all our work at PATH. So, and she continues expressing her support in all of our endeavors. And I also thank our friend, as Panda said, Abu Mayor, who has been always with us in whatever the instances, whether with funding or without funding, or for all our work, and has been getting the community to the reach for always. So thank you, Abu, for joining us and making this a wonderful session. And also thank another friend, Ashwin Yash, we call as him Yash. So thank you, Yash, for joining us and sharing your experience from the National Viral Hepatitis Program, and also being a community representative in this NVHCP committees. And I also thank Dr. Umesh Chawla, who's again a friend who has been continuing to work with us for HIV, and now we are together on viral hepatitis, and looking forward to collaborate with you for a larger work. So thanks, Umesh, for joining us and put your thoughts on your experience at the strategic information part of the viral hepatitis program. I'd also thank Rajkumar Nanikanta, fondly called as Kanta. Thank you, Kanta. Like your experience, particularly on the same day initiation of hepatitis C, it's going to be a learning lesson, not only for India, I think, across the region. So thank you for sharing that. We are looking forward to working with you and make more community-related strategies that will help not only hepatitis C, also for hepatitis B and other hepatitis wherever applicable. Thank you for that, sharing. I want to thank Dr. Kim. So thank you very much for joining us, taking your time immediately after your travel from Australia. And your experience in Myanmar actually help us going to for the hepatitis B vaccination, as you highlighted that very much with the engagement of civil societies in the country along with the government. So thank you for highlighting that, and we're looking forward again, as Kannan was discussing with you. I know like we are planning to work together in Myanmar for viral hepatitis and other issues related to that. And I would like to thank my own colleagues, the entire team at PATH. So PATH, as such, like we have a bigger team. Like it's not who we are seeing the screen. We have a HIV and viral hepatitis team together, which are working across the country now. And this is a perfect model. Pauline, you can always advocate that. This is a perfect model where we are leveraging both HIV and viral hepatitis resources together. So that you can advocate, and it could be a model across. So I would like to thank all my PATH colleagues here, and particularly Neeraj Jain, Dr. Satya, Dr. Asha, who is also not with us, but still she's always the source of energy for us, whatever we are doing. So thanks, Dr. Asha, for this. And also I'm thanking all the participants who have been gathered here. We saw around 112 participants who have been with us. And so thanks for joining with us, and wonderful questions, actually. So thank you for all your questions. That has generated a lot more discussions, and we committed like to your questions, like we make sure it is being compiled, and the responses for each of your questions will be reaching you soon. So that commitment will be given by PATH. And if there are anyone that was left out, I apologize for that. And if there are any technical and other arrangement related issues, please feel free to contact us so that we can build in our future webinars in a better way. So we are looking forward for building a dynamic partnership with across all the South Asia region, particularly with all of you. So we can always reach each other for further moving ahead. Do let us know how we can improve this next time, as I said. And we want to close this session all together by saying, we are not waiting. Thank you.
We are not waiting.
Yes.
We are not waiting.
Thank you.
Thank you.
Thank you all. Thank you all.
Thank you.
Thank you.
Thank you, everyone.
Thank you, sir. Thank you.